I'm really happy to be here. We have a lot of clinical information going on in California. As you know, cannabis has been legal as a medical substance for 20 years. I've been seeing patients for the past 12 years. And over the past 5 years, I would say, the incidence of cannabis use in the elderly has totally skyrocketed. When I started, it was maybe 10% of my population, and now it's more like 50% in the age of 60 and above, all the way to my oldest patient is 104 years old. So, okay, I want to start by, I don't have a video, but I do have a little story. This is patient Stewart, who's 86 years old, and he wrote a little op-ed for our local newspaper in Santa Cruz, California, where he said, "For some years, I've been dealing with progressive numbness and fierce pain in my feet, a consequence of peripheral neuropathy that began when I had diabetes. I had trouble sleeping more than a few hours at night. An old friend suggested that I try some medical marijuana that he and his wife were using for sleep with excellent results. He gave me a small bottle of the drops." You will hear about the drops. "And the result was also dramatic and immediate. Since the first night I tried the drops, the swelling in my ankles and the peripheral neuropathy pain in my feet disappeared. And for the first time in many years, I sleep well every night and for as long as I wish. This development truly stunned me. 2 neurologists and my competent and caring regular doctor had told me that the neuropathy was progressive, incurable, and untreatable. I have no pain anywhere. I'm sleeping better and longer than I have in years and feel a marvelous general sense of well-being and energy without the lingering consciousness of stress, all without having to make anything, to smoke anything, or waste a lot of time giggling." So I'm still seeing Stewart. This is about 4 years later, and his peripheral neuropathy has progressed. And he has started to use a different product for sleep, which has a lot more THC in it. And he is still sleeping well and through the night. And the limitation on how his peripheral neuropathy has progressed has to do with building a tolerance to the CBD and being unable to financially afford the kind of dosing that he needs to get to. So he hasn't been able to really follow my instructions as far as how much he needs to take. For example, a 15 milligram dose of CBD 3 times a day would probably keep his neuropathy in check, and he's only able to afford 10 milligrams once a day. And this, in case I forget to say it later, is the most limiting and the most frustrating factor of working with the elderly, because many are on fixed incomes and they simply don't feel that they can afford the medicine. Some of them truly can't afford it, and some of them are like, "You're asking me to spend $200 a month on medicine, that's just too big a piece of my pocket, and I can't do it." Okay, I'm not going to read this one. You'll have copies of all this. This is a half-hour talk that I'm putting in 20 minutes, but we see here some very infamous drops, which are going to be in a study that I'm going to be talking about. This is Bobby. She's 82. She can dance again, and you see her arthritic hands there holding the drops. Okay, so to begin with, we do have an informed consent sheet on my patient intake questionnaire. And one of the things that I had on there were the risks of THC cannabis, which for years, like for 10 years, that was what was on the risk list. And I'd have all these older folks come in and they'd start to read about this informed consent and risk listing, and they'd say, "Well, I don't want to come in and do this. This is like, I'm scared. I don't want to get dizzy. I don't want to have memory loss." So I had to create an additional section on the risks for CBD use, which most of them were going to be using. And as you can see, I never saw a risk for CBD use anywhere. I made this up, and I could only come up with 4 items. And you know, the change in mood or sensation is usually a positive thing. And here's a good one, though. Many patients do not sleep well on CBD. That's for another talk, so that's something to consider. And dry mouth and loose stools. So that's what they learn about before they come in. I don't have time to go through all of these, but we see that both THC and, in the next slide, CBD have many available therapeutic uses. And the important ones I want to point out here with the THC is that it's analgesic and anti-nociceptive. We don't necessarily see that as a primary component of CBD use. People may disagree with me. I get people that call me all the time saying, I want the pain medicine that doesn't get you high. I want the CBD. And if it's inflammatory pain, then indeed CBD helps. But if you're working with the central nervous system, for example, you want to get off opiates, I have found that CBD does not help nearly as much as THC. So there are uses for THC that are important, even in the elderly. And I'll show you how we bring it in without causing psychoactive effects. And then, of course, the main things with CBD are that they're anti-anxiety. Antipsychotic is the most important effect that I think is important because you can use it in combination with THC to actually get some benefits of having THC in your system while not getting, disoriented. Really important effect of CBD among many others. Okay, so what we do when we consider using medicine in the elderly, at least, is to start with the concept of you can use a CBD-rich medicine. You won't have to worry about losing your balance, about being altered in your sensation, and a lot of the elderly really like that. They will eventually go to a more THC-rich medicine for sleep, but they like coming in with this idea that they're not going to be stoned. And just some information about CBD. It does have this wide range of effects, which I showed in the last slide. But it's important to remember that, as in all cannabinoids, it does have a dose-response curve that's biphasic. So dosing is very important in both CBD and THC. And you have to work with your patients on follow-up visits for dosing, or it falls apart. This is true of all age people. And so in California, the model is that you see patients once a year, you give them an approval, they go away, you don't see them for a year. But if you really want to work with dosing, you have to see them like at least again after 1 to 3 months to help adjust to that naive user to the user that has developed a tolerance. And you have to adjust the dosing, and you have to deal with tolerance. Okay, there are some risks of using cannabis in the elderly. This is from the one article that I could find in the Journal of American Geriatrics that spoke about use of cannabis in the elderly. There are no articles, there's nothing written really that I can find that has to do with any studies done of people using cannabis in the elderly as far as, a published study. There's a lot of anecdotal evidence. So what they say in this article is that older adults are vulnerable because of age-related physiologic changes, comorbidity, polypharmacy, which increase the likelihood of adverse drug effects. Now, this is what's interesting because we're going to see that when we use cannabis, we can decrease the polypharmacy, and we're going to decrease the likely advent of drug effects. So this is an important reason why you do want to use cannabis in the elderly, is to decrease their pharmaceutical usage. And of course, lack of information about safety and efficacy. And this is really true, but you have to keep in mind that most of the opinions that come out about cannabis and its use in any patient population is based on age-old ideas that have to do with THC-rich cannabis, which does have its value, but that's not what we're primarily using in the elderly population. Okay, there was this, having said there was no studies, sorry. There was one study done in Israel about the use of cannabis in a nursing home, and most of the residents there did document dramatic physical results, weight gain, reduction of pain and tremors, and help in mood and communication skills. This was done at the Hadarim nursing home. Many of our Israeli members here will remember this. And what I want to point out about this study is that it was done with the raw bud marijuana, so it was either smoked or vaporized. And that's all that was available at the time of this study. We are very fortunate in the United States. I don't know about every single state, but in California, we have almost all the different forms of cannabis available. The one that I find most useful for the elderly are tinctures, those, and I'll come to that, but generally alcohol extracted full plant extract in a dropper bottle because we can regulate the dose by the drop, and it gives us a concentration range that's useful for the elderly, anywhere from maybe 2 or 5 milligrams of cannabinoids to 10 to 20 milligrams of cannabinoids. That's appropriate for an alcohol tincture. Okay, so because there wasn't any information out, and I have so many elderly patients, and fortunately, many of them resided in an assisted living community, it was easy to gather just some data, get a questionnaire, and this is by no means a study, it's a survey, but we did take a survey of some of the patients in a senior community in my area. To reiterate what was said by the last speaker, there's a problem in skilled nursing facilities, anywhere where nurses have to write an order. We can't write orders for cannabis. This affects not only pediatric patients, inpatients, but elderly patients in skilled nursing facilities. So there is a problem in getting the elderly to be using some of these cannabis products. This particular community had assisted living where they could choose to use what they want and administer to themselves. But when and if ever they had a condition that required a progress to the skilled nursing facility component, this is not even hospitalization, just skilled nursing, they had to come off of their cannabis. And all of the polypharmacy reduction that we had gained went out the window. They were back up on their 3 or 4 more drugs. And at the time that I did this study about 3 years ago, there was not any way around it. I wasn't the primary physician at this skilled nursing facility. I would have been willing to write an order, but I couldn't because I didn't have privileges there. The primary physician wasn't willing to write an order, risk his DEA license. So I'm happy to say that there are now 1 or 2 physicians in the area that I work that do come on staff at some of these facilities that are willing to write orders. And they say, patient may continue cannabis therapy. That's what they say. Patient may continue cannabis therapy. And that's enough. It's not hospital, but it's enough that the nurses will allow the patient to come in with their note from me, which I say, this is what I recommend the patient use. So between those 2 pieces of paper, then they're getting their medicine. So that's how we've done it. And I really think that nobody's trying to shut any place down for a few older patients continuing to use their herbal medicine. And so the nursing home was happy with it, and the patient's happy with it. That's how we've gotten around it.
Quick question.
Yeah.
When you talk about developing a tolerance, I assume you're dealing with receptor downregulation.
Yeah.
As the least of all evils to counter that, would you ever consider short-term cycling off of it to allow the receptors?
I'm going to talk about that. Okay. Thanks. Okay. So moving on is going into the study, the survey, I should say. So the participants in this survey all live in a retirement community in California. I already talked about that. This is important. All had access to advice from a team of professionals. So the primary physician on call at this assisted living center was on board. He actually referred patients to me. The resident nurse manager became very interested in cannabis and was a facilitator so that these old folks actually had someone to speak to on a daily basis if they needed to help them kind of navigate their way through using cannabis for the first time, and then they had access to a cannabis specialist, myself. And there is Karen, the nurse manager, dispensing the drops. We'll come to them. So the medicine was administered by the patients themselves. She might have taught them how to do it at the beginning, but they took it themselves. This was a survey. The people in the survey, 1 to 7 months at the time of the report, they'd been using cannabis. Almost all the patients were naive before they started. At this time in this part of California, there was no dispensary allowed. There was no dispensary, that the patients could go to. So we have delivery services, and there were 2 or 3 delivery services involved in bringing the patients their medicine. So you'll see a couple of different medicines here. Back. Well, all the patients chose to use it in a non-inhaled manner. That was the last sentence there. So this is the questionnaire. You can read about that later. I want to get the results in here. So the kind of medicinal cannabis that the patients chose to use, because we did this as a retrospective survey, so we didn't tell them what to use. Topical tinctures and edibles. No one chose to inhale. At this time, we had some problem with finding out what was in the medicine they used, because not all the materials were required to be lab tested. Therefore, not all were, but many of them were, you'll see. And not all the products delivered to the elderly come from a reputable delivery service, nor do they come from a reputable dispensary that will even honor, if you're lucky enough to have a consultant tell you what they want you to take. They'll go to a dispensary, they'll be out of the product that you want them to take, and they'll give them something else. This happens all the time. It's a big risk. I can't tell you how many times I've had patients call me and say, I couldn't make it home. They gave me the wrong medicine. I took it before I left. I had to pull off the road and call 911. At least 3 times. So we don't have any control of that. It's a really big problem. We don't have any control of what the patients take. All we can do is advise them. Okay, so this is just a review of the cannabis used. There were 2 different tinctures. One that's important is the glycerin tincture. As you can see, it had a concentration of about 3 to 4 milligrams of cannabinoids per milliliter. The alcohol tincture more commonly has anywhere in the range of 10 to 13 milligrams per milliliter. The patients ended up self-titrating how much they used, which will be in the next slide. They used more of the glycerin tincture, less of the alcohol. So the idea about self-titration and dosage really turns out to be true. Other products that they used were the cookies or the chocolates. These were taken before bed at the suggestion of the delivery driver, who said, well, if you want something for sleep, use this. This mostly had THC. It came as a shock. Many of them were not prepared. But since it worked, they continued to use it. We also had topicals, and we had a couple of folks using flowers boiled in tea, and it really helped their pain. So presumably they're getting THCA out of their flowers boiled in tea. Okay, then this is just a review of the patients' ages here in the left-hand column, 78 to 97, what their dose range ended up to be from their various medicines, and we can see that we have something from about 0.5 milligram up to 42 milligrams. That's the range that the patients self-titrated into, mostly focusing around 10 to 15 milligrams. And we can conclude is that the patients do self-titrate to an approximately, around the 10 to 20 milligram dose range, some more, some less. And the problem with topicals is that they're used to a medicine that this was not given with direction. Like, it lasts 4 to 5 hours. You have to use it 3 times a day. So they only used it once a day. So they really need direction on every single thing. Okay, the last of this study is the different diagnoses that the patients were seen for, mostly centering on peripheral neuropathy, arthritis, and insomnia. And you'll see on the right-hand slide is the change in medications. You can look at that later. In almost every case, patients reduced their medications or went off. This was done by themselves. There was no doctor supervising this. This is just a report at the survey of what they did. And so just some feedback about what the patients said is that they wanted to reduce their pharmaceuticals, experience less pain, have better sleep. In the small group of patients presented here, these goals have been met with varying levels of success. Most of all, some patients received considerable reduction in their other medication use. And Overall, what we learned is 2 years later, 10 of the 12 patients were still taking cannabis medicine. One who had discontinued resumed after she came for a follow-up visit because she was confused. Now 14 of the 24 residents use this medicine, and in the cases of discontinuous, it's due to lack of education and inadequate follow-up. That's most important with elderly. They need follow-up. They get confused, they forget. They're not sure if they're supposed to keep spending this money or are they cured now. That's really important. So I think I'm pretty much out of time. Oh yeah, here's the last slide. The biggest response that we got in this survey was we were afraid to use it during the day. So we had a lot of people that had pain throughout the day and only achieved remission of their pain at night because they were afraid. But if they came back and they spoke to me or they spoke to the nurse manager, she encouraged them to use it during the day. Another patient came in complaining of insomnia and back pain, but he was so afraid to use the medicine, he stuck with the topical only, which of course is not going to help him sleep. So that's some of the patient feedback, and wow, I spoke so fast. I have 1 minute left. This is amazing. So I can tell you a little bit more about the elderly that I treat now. We have patients that come in on their own. Their families bring them in. I have 4 or 5 different communities, assisted living communities where the patients are coming in. A lot of patients come in because their son or grandson or some younger person is bringing them, but almost all of them are coming in because of this held out miraculous hope that they can use CBD or they can use the medical marijuana, the one that doesn't get you stoned. And they have to be educated that there are combinations of CBD and THC that can be had that can help them sleep. For example, this tincture that we used was early days of tinctures, and it was a 2-to-1 mix of cannabidiol to THC. So that 35% of THC, actually this strain, cannatonic, is pretty sedating. It actually did help them sleep. So there are ways that you can do with strain selection and ratios that you can get the benefits of THC into a non-altering medicine. Last of all, I promised to talk about tolerance. I'm on red. Oh, I went the wrong way. Yes, they need to come back. We need to talk about taking a tolerance break. That'll have to be the subject of another talk. Thank you.